A few more minutes for discussion. I would love to hear from the audience. So do we have microphones for people? I see at least one. I see two. All right, we've got microphones, so please raise your hand. We are streaming it and recording it, so we would like you to wait a minute for the microphone to come to you. And then the one other request I have is just introduce yourself very briefly. And with that, we have one way in the back, near a microphone.
Thank you for all of the information. I'm a family physician at one of the community health centers. So when you talked about involving everybody in the community, that includes families and everybody else, the ideal place, this is just a suggestion, because I do work at a community health center and I do want this opportunity of these free kids coming to my clinic. So I was suggesting, just like how pediatric patients come in sequentially for every little cough, cold, including vaccinations like 2 or 4 months, newborn checks. It's like a sequence of events, right? All the way till they're like 16. You have these predictable pattern of visits. And we also have patient portal. And we're about to launch telemedicine. So I'm thinking, how about incorporating all of that? Because I do teach Stanford medical students, so I do use them as patient advocates. So I'm like going all over the place right now. So that's what I was thinking. Like if you catch pediatric visits and just like you give the VIS vaccine information statements, just like that, you could actually start talking about all of this, not just about genomics, but also about the lifestyles, because that's when we start talking about it in pediatric. Like basically these mothers, we see a whole family at community health centers. It's just not, my patient is just not the pediatric. It's also the mother as well as the grandma, the whole spectrum of the family dynamics. So basically that's what I was suggesting. Like if you could come to my clinic, we would launch it.
Any of the panelists want to comment?
I think it's a good idea.
We also have in the patient portal actually advertising Stanford research, because I myself started a company in 2009 where it displays all of the resources in the county, not only Santa Clara County, but San Francisco, all of the counties. So right now, Stanford and UCSF have been advertising for these patients. I just put the plug into the patient portal. So we have direct access, and now September, we're going to be launching telemedicine. So I'm thinking, I'm looking at Rhonda, thank you for inviting. I took this opportunity. That's exactly what I was trying to do, population health. And I envisioned in 2009, research is the way to go, because you see, like one mother is from multiple ethnic groups. I don't see pure Indian lineage. I don't see that. So it's very important that everybody's included. My population includes one child from 4 ethnic groups.
Incredible. Thank you. We've got one back here.
Thank you. Is that me pointing at?
Yes.
I'm Colleen Krangle, and I'm here from PLOS Medicine journal, because we are very interested in receiving submissions on research that works to reduce health disparities. But my question right now is about data. If there's one thing that characterizes precision health, it's the data, not only enormous genomics data, but as a number of people have said, the environmental, behavioral, the social. What do you see as the biggest challenge to making proper use of this data that's facing us right now?
It's a wonderful question. I'm going to take a real quick swing at it myself from the perspective of the work we're trying to do here in the Center for Population Health Sciences. And then I'm sure I want to hear Sandra's perspective, because there are huge, as you well know, huge ethical issues involved in the use of such data, much of which was collected not for research purposes initially, but observationally, and hence not consented in the usual way. But I just want to briefly mention, so that there's no confusion, because in the big data era, there's often the perception of, now we have big computers, we have all these informaticians, we got great computer scientists, so all the technical problems have been solved, and the only thing left is to assemble enough people, draw enough samples, get enough sequenced, DNA, metabolomics, whatever, and the answer will drop out, because we have, of course, great observational research methods. And the answer, as I hope everyone knows in the room, is we are not there yet. And I just want to put in a huge plug for the enormous amount of developmental work that needs to go on in every one of those arenas, even as we hopefully educate our partners in the community to participate at their end with helping us collect and bring that data. But there are unbelievable challenges in developing the data platforms, both from an engineering point of view and from an analytics point of view, that many of us are actively engaged in. But Sandra, talk to me a little bit about the ethical issues. I know you were very actively involved in trying to understand what is it that people want from research, and how do we deal with the complexity of our consent versus looking passively at this enormous amount of data that we can now, for the first time, do without consent.
Yeah, no, consent is a huge issue, as you can well imagine, just in terms of which data has been consented to be used for what and for by whom. So what we found is that individuals, they care about the research question, but perhaps even more importantly, they care about who's using the data, and particularly when it creeps into a non-health context. So you can imagine the triangulation of all different types of data, and one of the biggest concerns among our participants was, gosh, is the government going to be using this data in some way that I can't even foresee at this point? And that's really the challenge, right? Because there are no, we're asking individuals to imagine a future that we as researchers can't even imagine. And we're asking them to oftentimes consent broadly. And so that's where I think, where some of us are thinking about, can we get beyond consent? Can we have structures in place that attend to the research relationship in terms of where the research is moving? We communicate back to those participants in terms of the kinds of questions that might be asked from their data, and to have them part of that process. It may not be consent, but it could be in the context of oversight. And again, this idea of trying to create trust moving forward. And that's where the innovation really needs to happen, I think.
Either of our other panelists want to comment?
I think one of the challenges, well, there's a lot of challenges. So our group just finished our analysis of one of the largest whole genome sequence projects in the country right now for children. So we had over 2,000 children, all with whole genome sequence data, as well as social determinants of health data, environmental data, and their clinical characteristics. Our first problem was finding a place to put all of the data, just storing it, being able to manipulate it. We had to create an entire new infrastructure just to get the file open. So that was step one. Step two was, after we'd actually gotten everything open, we had to figure out what it was we were going to do with it. And I think the only way we were able to do that was that we had a very diverse team. I'm a geneticist. My background is statistical genetics, but I'm not an epidemiologist. I don't know how environmental impacts are going to affect our outcome. I'm not a social epidemiologist, so I don't know how the social determinants of health are going to affect that. We had epidemiologists and social epidemiologists on our team. We had people from bioethics who helped us understand, how to make sure that we weren't taking advantage of our participants' trust, because they were trusting us with their data. We also had Native American samples. We wanted to be very careful that we didn't kind of betray that trust. We had clinicians as a part of our group because, other than an outcome, I really don't know, how health works. So we had the MDs for that. I think just having that diverse team, everyone having their own niche and being able to work and speak together is what really helped us to be productive. Because it's not going to be one discipline on its own that really makes the breakthroughs. It's going to be these multidisciplinary, collaborative teams. And I think that is one of the challenges, because UCSF is really the only environment where I've had that. All the other places where I've been, we've all been geneticists. And that was all that was in our group. So if it wasn't genetic, we really could not help you. But now, I think with the current environment of science, that's just not going to be as useful as perhaps it once was. So really having these collaborative groups, really having the infrastructure to handle the big data is what's going to move the field forward.
Joanna?
Let me just add, sometimes there's pressure to gather big data, and that pressure can actually be a problem in itself. So we actually have NIH funding to do whole genome sequencing for some number of African American individuals in order to develop a reference panel for imputation, which could be very valuable in the statistical genetics world. And the strength we have there is that we could invite tens of thousands of individuals, describe the project, and we didn't need all of them to agree. Fortunately, thousands did agree, but there wasn't the pressure. We have to get this person to agree to participate. Having a broad set of individuals who were invited to participate and provided with all the detailed information of what will happen with your data, and that it will be placed in a public repository and so on. We provide the details, and then people get to choose whether they're comfortable with that and trust us and the broader system enough to consent to participate. So that is another piece that I hadn't heard, and again, it ties back to many things, the education and the trust and so on.
Thank you. Don?
Thank you. My name's Don Barr. I'm on the faculty in the School of Medicine. I'm trained as a physician sociologist, and I teach about social determinants. Many of the presenters have used the racial and ethnic categories identified by the U.S. Office of Management and Budget and the Census Bureau. But the research here at Stanford, Noah Rosenberg and Marcus Feldman have done global research using both microsatellites and single nucleotide polymorphisms and various different numbers of divisions. And what they have found is that these categories are really rather arbitrary and they change over time. For example, Hispanic may likely change from an ethnicity to a race based upon Census Bureau policy in 2020. So the concept that these racial and ethnic categories are largely socially constructed and not genetically constructed, how does that affect this type of research?
Marquitta? Well, any one of the three of you could talk about this from one point of view or another. Maybe we'll start with Joanna this time.
Okay. So I kind of was trained, in that milieu of, understanding that the correspondence between genetics and these social categories is very rough. And so when I started at 23andMe, that was sort of foundational to the way we were thinking. So we didn't use the terms until NIH asked us to tell us how many people in this research are African American, how many people are this, and so we had to start asking people. We actually had ways of using genetics to kind of infer what people might self-identify as, but we think it's most important, since these are social categories, how do people describe themselves? So we then went into adding to our surveys, how do you describe yourself? Many people check multiple boxes, of course, and so we have had to use the partly for NIH reporting reasons, and the IRB asks us. So all these official entities ask us for these, to group people according to these categories that really don't have a correlation with genetics. And we're a genetics company, and therefore we get caught in that trap. And then come to a meeting like this where the words ethnic and racial are in the title of the organization. And so then you kind of get drawn back into using these terms. But I like to be very specific, even talking with my colleagues at 23andMe. Why are we using these? Are we asking the questions in this survey? They're for a very specific reason, for reporting reasons, or because the only studies that have been done about some mutation have been done in certain populations. And so when we report back to customers, we want to tell them what has been learned learned through study of this population or that one. So it's most relevant if you are part of that population. So we may ask people for that reason, do you consider yourself to be French Canadian, or, we ask some kind of cultural group questions for the very reason that it's for how we report your results back to you. So I think if you tie the use of the labels very clearly to usage, you can kind of avoid some of the pitfalls.
Marquitta?
So, as I said, my training is as a population geneticist. For me, race and ethnicity are definitely a social construct, but it doesn't mean that that construct is not useful sometimes in research. For my research, I prefer to look at genetic ancestry. It's something I can measure. It's quantitative. I can tell you the percentage of your genome that came from this continent or that one. I cannot tell you the percentage of your genome that is, say, African American. That's not a thing I can measure. That's how you self-describe yourself. However, these ways that we self-describe ourselves may indicate cultural experiences or shared environment, shared techniques that might actually shed some light on why this particular group is having a difference in disease susceptibility or disease severity. So I definitely don't think that it should be ignored. For my research, what I like to do is measure the ancestry and use that as a quantitative trait. But I also do pay attention to how people self-describe, because it could be really important. So I use it as a covariate in a lot of my analyses, or I'll look in each group individually, just because I don't want anything to kind of be washed out, and I want to focus, my attention on one population versus another, probably the population with the highest risk. I work mostly in asthma. So in asthma, Puerto Ricans are the highest mortality and asthma susceptibility of any self-described racial ethnic group in the country. Mexican Americans have the lowest of anyone in the country. It's kind of important to me, like how people who self-describe as Latino, if they self-describe as Mexican or Puerto Rican, because then I kind of know, okay, it seems that this group is tending to have a really high risk, and this one has the lowest risk. Let me look in just this group and see if there's anything that might be associated with that. But I always take into consideration the genetic ancestry, because even within groups, these groups are not homogeneous. So the ancestry is going to vary within groups the same way it varies between groups. So I think that being very careful with how we use the information that we have is going to be important as well.
Sandra, before we wrap up?
Excellent question. So that type of slippage that happens in terms of how we're thinking about the social construction of race and how it operates as a variable is, it's very hard to unpack, right? When we just spend a lot of time trying to unpack it. And we have to, I think we shouldn't be naive in terms of how the public is consuming this information and the power of genomics as an explanatory model. People will conflate race and genetics in ways that are problematic. And I think if we confront that and participants talk about the fear of stigmatization in terms of genomics, it's very important to be able to decouple that and really be precise. Maybe that's something precision health can help us with in terms of the precision around how race is being operationalized and really taking to task what we think we're explaining with that term that's a proxy for so many different things.
With that, maybe we have time for do we have time for one more question? My timekeeper says we do. We'll take one more back here.
Hi, my name is Quyên Vong, and I run a nonprofit organization working with Vietnamese children and families in Santa Clara County. I think overall precision health is a good thing, but I was just wondering if anyone has done thorough looking at the different perspective about this whole thing. Number one, from a cultural stigma and mental health perspective, has anyone done any research on to find out what may happen to the people like Lori after they found out that this has been confirmed, this is genetics in my family? How does that affect them? And how does that influence or impact the stigma in their own culture and their mental health as well? And the second perspective that I was wondering is, after all of this, like the Lynch syndrome, if I were the insurance company, I could very well request that test. And then based on that test, I charge the premium. So anybody is working on that front to lower that? Because in this country, the rich takes care of themselves, the poor is taken care of by the government, but those in the middle get hit the hardest, right? Those in the category I call not poor enough.
Anyone want to take a stab? It's an incredibly important and difficult question. And I'll at least say this much: there is certainly work going on, including within our own center, at looking precisely at how folks from different cultural backgrounds respond to the information. Dr. Paracoil, I see, walked in, who is the principal of our third project, looking especially in Asian subpopulations, including your own, at the different ways in which individuals and their families, in fact, and their providers react to the information, share the information or not. Again, mostly at this point in time, so we better understand what the impact of this is. But I'm perfectly happy if someone feels they can more fully answer the question. I think we're at the beginning of time, and one of the deep concerns we all feel in tiptoeing into this area, and one of the reasons that I think the consortium core, which hosted us today, has put so much energy into the whole issue of trying to understand what the community thinks at many, many different levels. Vijay, do you want to comment at all on that? I'm not sure you heard the whole question, but really what the impact may be of increasingly sharing genetic information with individuals who come either as preventive screening or in the course of treatment for a disease.
Yeah, glad to share what we've learned so far. It's exactly as Dr. Cullen said, we are just in the very beginnings of this. What we are trying to better understand is the precision part of it is in the medicine, but then the more larger part that we often don't think about is how we communicate the precision part, because what patients do is really dependent on what they understand or not. And so we are actually we're doing audio encounter taping of these conversations about genetic risks across different cultures, across the languages, across socioeconomic barriers, to better understand what is it that we are telling them, what do they understand, and how does that impact their care. Because I think we get the test results and we would like to believe that the minute you get the test results, everything is solved. If you really think about it, that's when the game starts, right? When you get this next-gen sequencing or whatever results, how do we communicate it? What does it mean? And with many of these ethnic patient populations, there is an increased prevalence of variants of unknown significance, which means we really don't know. We have all these results, and so we are more confused than when we first started. And so how do you convey that to patients in a way you can help and impact their care in a positive manner? So more information often is not necessarily more clarity, right? And so that's the fine line we have to walk, and we are learning from patients in terms of how to do that.
I guess it gives us plenty to talk about next year when we convene. With that, I want to thank these panelists for a terrific performance. These are tough, very, very, very tough questions. Just quickly, because our time is limited to close, a couple of things. First of all, before people leave, you might want to just take a look at the stars, not the stars in Frontier, but those stars on our galaxy board. Here are, do we have the word cloud? Do we have the word cloud? I don't want to preempt the word cloud, but these are some of the definitions, and there are many others that are on the board. Can I advance this? Or? No, there's no cloud yet. Someday there'll be a cloud. We'll send it back out to you. I do want to thank a couple of groups. First of all, for all of our speakers It's amazing what you can pack into a couple of hours, and extremely impressive, extremely impressive. I can take no credit for it. That credit goes to the consortium core leads, Rhonda McClinton-Brown, Lisa Goldman-Rosas, Jill Evans, who's our absolutely fabulous executive director, and I think responsible for planning much of this, and then our wonderful staff, Linda running around with the microphone and back, and Gita sitting up front. I saw Kendra floating around also with the microphone. I've probably, Glenda's hiding because she doesn't have the word cloud now. And Glenda, really a fabulous performance. And again, for those of you who are staying on for the Consortium Core annual meeting, hope you have a good afternoon in this terrific venue. And for those of you who have come from the community, I want to triply thank you. None of this would even be a reasonable thing for us to do without you. I mean, it's more than a partnership. It's a kind of an all or nothing kind of a thing. And although this will move slowly for all the reasons that your questions have suggested, this part is actually the part that will require the most careful attention. Godspeed to the people in the laboratory doing the cutting edge technical science, but this part is equally important and hard. So we will see you, and thank you for your great support.